Good morning, friends. I'm Dr. Rajesh Pandey. I work at the BLK Max Super Specialty Hospital, New Delhi. In my last more than 30 years of experience as a specialist in critical care, earlier I was, training MBBS, MD, BSc nursing, and BDS students. And when I moved from the medical colleges and institutions to private hospitals, I am involved from almost 1.5 decade in teaching training of DRNBs. Earlier it was called FNB, and also IDCCM, IFCCM, and the nurses, etc. And what I have felt, in last 35 years, that we do not receive training in certain aspects, be it medicine or critical care. I remember when I was a medical student, and the first CPR training was given to me by my head of surgical, professor of surgery. And he had a mannequin. I'm talking of 1984-85. So he showed us a mannequin, but because the mannequin was too precious, we were not allowed to practice it over the mannequin. But at least he was sensitive to the need, and he introduced us to the subject of CPR, demonstrated it on the mannequin. And after that, there was a big gap. And finally, when we joined the MD program, and later on when we specialized into critical care, that time we realized that this is very, very important. And for last 20 years, we have been doing all the AHA ACLS courses. So it's all a new phenomena. It was not there when teachers like us were, students. Similarly, we are never told about the human aspects of critical care. We find completely at a loss when we are facing situations where the family is grieving, or we are being questioned about why the patient's condition has deteriorated, or when we face an aggressive family, because this was never been a part of our critical care curriculum. So today I'm going to talk about being human in the ICU, which I feel is a very, very important component, and all the students should know about it. So the critical care staff are organ management centric in ICU. So we'll talk about SOFA score, look after different organs, do an ABG, try to correct metabolic status of the patient. So we neglect what a critical care patient on the brink of death is experiencing. And we oftentimes fail to appreciate that our patients are unable to speak. They are half naked in a hospital dress. They have tubes and pipes, and they are being restrained also by the nurses. If they are, aggressive, or if they ask too many questions, or at times, if they are too demanding, the common remedy is to restrain them. They most of the time are hearing disturbing alarms, which they do not understand, and they are also surprised because they feel nobody is responding to these alarms. So because we become immune, and for the patients, they cannot distinguish that these alarms are non-serious alarms versus serious alarms. So they find that staff is unconcerned, then why at all have the alarms there? And another problem is they are being prodded, poked all the time. So anybody would come, take a sample, examine them, do an ultrasound, do an echo, and they have disturbed memory. So oftentimes, if they have encephalopathy, they may perceive this as a different thing, and they may complain to their relatives, that they were being inappropriately handled. Encephalopathy therefore complicates it further. And when they are so sick, when they require so much, from their family, unfortunately, the family is away during all these difficult times. They are waiting outside. We tell them your patient is too sick, so you come only during visiting hours, when we will tell you about the progress of the patient. And they are not allowed to be with the patient. So a big question that comes to mind is, should the patient and family surrender all control in ICU when they become critically ill? I mean, they leave it to the judgment of the nurses, the support staff, and the physicians, and will have absolutely no say in how they have to be managed and what are their personal preferences, personal choices, and other things. Another question that comes to mind is, why do we do it? Why does it occur in the ICU? Why is it so frequent? Possibly high workload, and burnout desensitizes us to the human aspects of critical illness. So because we have seen so many similar cases, it doesn't really affect us. Somebody, for the family, it is the first time that it is happening. The patient is critical, fighting for his life. But for us, it's the 1,000 patient. So we are desensitized. Policies and cultures prevalent in ICU at the moment, particularly in the Indian ICU, also promotes dehumanization, because the idea is to take away control from patients and families and give it to the caregivers. Another problem is we have a fragmented care delivery models, shift work. Unfortunately, that's the way it is in critical care. It also prevents us from getting to know our patients as people, because it's not often that the same nurse will be assigned to the same patient. So maybe 2, 3 days, the nurse looks after the same patient. Once a bonding occurs, the nurse is assigned to some other patient, because there are differential needs in the ICU, and the nurse team leaders, and they have to assign to a more important patient. So the bonding between nurse and patient, doctor and the patient is fragmented. As a result, if you talk to them, they will say in that shift, these two nurses, these doctors, resident doctors are very good. I want them to be around me. But unfortunately, the system cannot provide for this kind of continuity. And we also forget that patients who seem unconscious may feel and remember what they are experiencing. So when we are talking about them, saying that they are so critical, that they are unlikely to make it, and this organ is failing, that organ is failing, and there is no fun in doing this, and the family doesn't have money to pay, maybe they are listening in their subconscious mind. So it's very bad to discuss these things. In fact, nothing should be discussed near the patient's bedside. We should move away a little bit and then discuss the clinical aspects or other socio-cultural aspects. Another reason why we are, oftentimes found lacking in the human behavior is we are not trained for this. So nobody has taught us, like I mentioned before, the importance of family bedside presence, physical touch, like holding a hand, the healing touch of the physician that is missing these days, calm words of explanation. We cannot spend so much time with the patient. So you are giving much less time to a patient, and the patient is not satisfied. He needs somebody to listen to him, to be with him. So he feels that doctor cannot even spend 5 minutes of his time, busy time with me. That means I'm not an important patient. So maybe he wanted to tell us something more, discuss something more, but then we shrug it off, move on to the next patient. And this happens more with chronic patients and stable patients. I mean, from patient perspective, all of them feel the same way. They want to know what's wrong with them. They want to be with their loved ones, and they want to be out of ICU as soon as possible. So the safety of the patient, the social, cultural support system of the patient, nobody has trained us in this aspect, that we need to look into these in deeper details. So when we look at the dehumanization and versus humanizing behavior in the intensive care unit, what the patient feels is that there is complete loss of identity. I was so and so, but here they have put a green dress on me, and I'm like everybody's similar, like in a jail. We also look similar. And there is loss of ability to communicate when they are intubated or they are tracheostomized. That is another big problem. And we do not provide enough material so that they can communicate by writing. And we do not have enough play cards so that they can point out to the problem that they are having. It exists in the system, but it's not put into complete practice. That is the problem. There is also loss of ability to advocate for oneself. The patient cannot say that this is wrong, this is hurting, and I'm feeling pain here, because he can't speak. And also he finds he is an alien environment where there is always, the area is lighted up, people are moving around, there's commotion all around. And oftentimes the doctors and nurses are, very, very actively resuscitating a patient. So these all things lead to a lot of, a lot of problem with the patient, and they feel that they are not in the right place, and they miss the presence of their family. There is loss of control, because at home they might be the head of the family controlling everybody, or in office they might be the head of office. Here they feel that they are at the mercy of the nurses and the doctors and the ward boys and GDAs. If they have passed motion, or if they want to pass urine, they have to get somebody. They may be holding their bladder, but nobody is responding. So these things are not uncommon in the ICU. Also, there is loss of respect. How many of us really talk to them by their name, Mr. So and so, and greet them and say namaste or namaskar or good morning? Very few of them. Normally, people will, talk in terms of bed number 1, bed number 2, bed number 10. So there is complete loss of their identity and there is loss of respect. Even though the number of elderly patients who are coming to the ICU more than 65 years of age is increasing, but we do not provide sufficient respect, sufficient safety, or family support to these patients. There is loss of modesty because oftentimes, if the patient is not in a single room and you are unrobing him for any test or anything or cleaning his private parts, he feels that, he's naked and there are others watching. So this loss of privacy also, is very, very important. It causes dehumanization. Purposeful shaming and mocking that you are not taking this drug, you are not eating your food. This happens. The nurses, the ward boys, those who are cleaning the patient, they may do have this kind of behavior. So they feel offended, they can't communicate, they cannot tell others. So they will communicate to their family members somehow when they come, and the family members would then bring it to our notice, then we take corrective action. Why is it not, the culture in the intensive care units all across? And we also exploit them for research. That's another thing, because they are with us. So we want them to be employed in some research control group or the other group. So, or use their data. So that is also considered now purposeful exploitation. Whereas humanizing behavior would be unrestricted family visitation policy, where the family is there to support them, to make them feel at home. And when we talk to them as a person, when we know them as a person, I'm not talking of the medical facts. We know that so and so is an engineer and he's working as a top manager in such and such company. He has a family where he has kids and he's fond of reading, he's fond of watching movies, fond of tracking. So, do we know about our patients? I'm sorry to say we do not know. Physical touch, do we ever put our hand on the patient's forehead or touch his hand or shake his hand? Please ask yourself, are you doing that for all your patients? Communicate with the patient, not just about or above the patient. So communicate, tell them today is Sunday, today is Monday, this is happening. The doctors are on strike in Rajasthan, or this is happening across the world. The war is going on. Are we communicating, trying to tell them about the day-to-day affairs? Are we providing them, if they are able to read, if they are recovering, do we provide them with a newspaper? And do we provide them with their glasses? Common courtesy communication, especially to delirious comatose patients. Oftentimes we ignore these patients. Why can't we say good morning or good evening to these patients? Why can't we explain the procedures that we are going to do to these patients? Why can't we tell them that you are better, or you are, this is what is being done to make you better? So introduction, explanation, what is about to happen, permission to touch is all the more relevant even to delirious and comatose patients. Attending promptly to patient needs. Somebody wants water, somebody wants to pass urine. Now somebody is having pain, somebody is having nausea, vomiting, they need to be attended promptly. Not that we'll only be attentive to the sicker patients and this patient is okay, doesn't have so much problem, he's hemodynamically stable, saturation is fine, so he's ignored. Individualizing communication modalities. So this is very, very important. I use the Google Translator in the ICU when I have to communicate with a Russian patient, with an Arab, or with an African, or with somebody who only understands French. At least some communication is there, rather than waiting for the translator to come and then only be able to communicate. So the patients feel happy that somebody is making an extra effort to understand what is wrong with them. And oftentimes it solves the problem. Giving patients some control of their environment. So unfortunately, there is no bedside control for air conditioning or other things except a bell. If we can give more control to the patients, for their environment, so that if they are feeling very cold, they can increase the temperature. So these things go a long way in humanizing our behavior to them. Use eyeglasses, hearing aids, dentures as far as possible so that they look normal. Personal hygiene, hair care, oral care, sponging, bathing. Now, these are normal things that we do every day. So the patient also requires this. Unless the patient is extremely critical, all the patients would require this to be done. But are we doing this for them? I don't think we are doing This is done more for patients who are recovering rather than those who are bedbound, intubated, or ventilated. People, it's not that the critical care physicians have not pondered over the issue. They have looked at this and come up with an ABCDEF approach, where A stands for assess, prevent, and manage pain. B stands for spontaneous awakening trials and spontaneous breathing trials. C stands for choice of sedation and analgesia. D stands for delirium, both assessment, prevention, and management. E for early mobility and exercise. Now, F stands for family engagement and empowerment. Very, very important. If the family is involved, if the patient finds that the family members are there and holding his hand, understanding, it provides a lot of comfort to the patient. So please, we need to change our focus. It's not only patient and professional, it is also the family. So it has to be, the care has to shift from patient-centric to family-centric care. So that is also a new dimension that people are looking at. Healthcare personnel, family discuss the information and goals openly. All perspectives like cultural, spiritual, religious, they are discussed, they are welcome, they are respected. Collaborative decision-making is done about day-to-day care and also about life-sustaining treatment. What are the priorities that is discussed among these? And it also empowers families and it capitalizes on their strength. It helps us immensely. It ensures that all parties are respected. And with input from families, family-centered, culturally responsive policies, practices, and systems can be developed, and these kind of things can be implemented. It is not uncommon. Like in my organization, multidisciplinary team meetings are mandatory for a patient who stays beyond 4 days, or as and when it is required or asked for by the family or the physician or the hospital manager. Now, this was an excellent article in NEJM Catalyst published in 2018, which looks at all the things that make our behavior more human. So open ICU visiting policies, communication with the patient or providing means of communication, being concerned about well-being of the patient, presence and participation of relatives in ICU, so they can be involved in feeding the patient, in grooming the patient, sponging the patient, bathing the patient. Care for the healthcare professionals, we should be careful for them. Prevention, management, and monitoring of post-ICU syndrome, which largely post-discharge, it is nobody's baby. Very few hospitals are having post-ICU care clinics. Humanized architecture and infrastructure. So they are thinking beyond that. The ICU should be designed so that the patients feel comfortable. They do not look like the prisons that we have, with absolutely nothing to provide comfort to them. And also it should focus on the end of life care, and patient should be allowed to have a dignified death if the need arises. And Spain has, as we know, Spain is a leader in organ transplantation in Europe and across the world. So they have done some extraordinary work. Now, this was basically incorporating animal-assisted interventions. And they did it for long-stay patients in the ICU because they feel that there is physical, cognitive, and psychiatric impairment, which constitutes the post-intensive care syndrome. So see here, the patient's dog has come to meet her, and this is like the bonding. This looks not natural to the patient. So they are allowing the pets to come inside the hospital and visit the patients and look at the happiness on the patient on the face of the patient. And here, the pediatric patient is visited by her favorite cow. So look at this is again from France. So this provides significant comfort to the patient. So these ICUs are walking an extra mile to provide all the comfort and making it as human as possible. Look at this. Hospital patient was taken to the seaside by ICU staff. This was published in Economic Times in India. This happened in Barcelona, Spain. So a recovering patient is made to feel that, the nature, he's close to the nature. So all these are efforts being made to humanize the ICU care, make them feel more comfortable in their usual environment. So lastly, we must consider that, patient is a human being. His personal liberty and dignity should remain intact in the ICU. Behavior of our ICU staff should be compassionate, caring, and humane. There is also a need for such training for all ICU staff. So unless we train our students in attempts to humanize the ICU, possibly the patients will continue to complain, and the divide between the patient and the doctors or the critical care physicians will continue to increase. Thank you very much. Thank you for listening to this video.